Assalamu alaikum. I am Dr. Jalal. So I am making a simplified videos so that it makes your orthopedics easy and understandable and interesting. So today I will be discussing about various elbow conditions. So anyhow, I have given the notes in the PDF format in the way you need to write in the exam. But in this video, I won't be just taking the lecture. We'll be discussing as a clinical case scenario. So we have a clinical case. Okay. If you are in OP, you got two patients who are 30 to 30 years. Two patients. And both of them have pain in the elbow joint. Okay. One of the patient is tennis player. The another patient is a golf player. So here I just want to know the little anatomy which we have read in your first year. So this is your simplified form of elbow joint. I try to be as neat as possible, but I can't control the pen. So if you see, this is your humerus. Okay, this is capitulum. This is trochlea. This is your lateral aspect, lateral epicondyle. This is your medial aspect, medial epicondyle. So we have the muscle originating from this. So this group of muscle originating from the lateral side, we call it as common extensor origin. The same way we have group of muscles coming from the medial side, we call it as common flexor origin. What is happening is in these patients due to repeated trauma, repeated eccentric loading of content, micro trauma is happening. This micro trauma is inducing inflammation. So this inflammation is at the condyle, uh, tendon and condyle junction. It is called as epicondylitis. So if it is affecting the lateral side, or it may affect the medial side. So if it affect the lateral side, we call it as lateral epicondylitis. And if affect the medial side, it is called as medial epicondylitis. So it's very important you should not exchange medial to lateral, lateral to medial. So how to remember the medial? So you can LATE. So late. So LA stand for lateral. So if it is lateral, it is TE, late, tennis elbow. Here you can remember it as Mahatma Gandhi elbow. So M is medial. So if it is affecting medial, it is golfer's elbow. So I did lot of time corrections of the paper, internal and external. So many people know when they ask lateral epicondylitis, they exchange with uh, this golfer's elbow. If they are asked for medial epicondylitis, they get confused with a tennis elbow. So you should not be very clear in that. That's the way. Lateral, we call it as tennis elbow. Medial, we call it as golfer's elbow. So here we have one muscle which is responsible for this. This is ECRB, extensor carpi radialis brevis. It is sometimes asked as PG between your entrance exam. Golfer's elbow, we have pronata teres and flexor carpi radialis. So golfer's elbow is seen in golf players or sometimes also seen in baseball players. And tennis elbow, as I told, tennis players or cricket batsmen also it is common. So this is the group of muscle which is responsible. So what will be the presentation? So what is the presentation? As I told, here we'll have lateral epicondyle pain. Okay. Here we have medial epicondyle region pain. So, and in both patient, grip will be disturbed. I mean, they have poor grip, holding any object or anything. So, how will you diagnose it? So, most of the time, it is just a clinical diagnosis. But if you want to confirm it, you can either do X-rays. So, X-ray most of the time it's normal, but sometimes no, in the muscles you will have specks of calcification. If it is a long standing microtrauma. So calcification specs. And if you do MRI, MRI will show edema, edema of the respective muscle. In cases of medial epicondylitis, pronata arteries and flexor carpi radialis. In cases of lateral epicondylitis, ECRB is inflamed. Treatment for lateral epicondylitis or medial epicondylitis. So no, we'll change this to here, otherwise it will get confused. This is lateral epicondylitis. This is medial epicondylitis. So here lateral epicondylitis treatment both is we need to give rest for healing of the microtrauma and NSAIDs. Here stand good same rest NSAIDs. Then here we can give splint. We call it as tennis elbow splint. Here also we can give some strapping. And if patient is having persistent pain, you need to go for intralesional steroid. So generally we give methylprednisolone or triamcinolone. So here also if the pain is persisting, you can give intralesional steroid. So if steroid along the common extensor or common flexor origin. Then if patient is having persistent pain, you can give Botox. You can give platelet-rich plasma. If there is no response, you need to do surgery. Surgery here is either you can go for endoscopic or open release, or you can go for ECRB lengthening, Z lengthening. Here, surgery is you need to go for debridement of the inflamed tissue. This is all about your tennis elbow and golfer's elbow.